Thank you, ma'am. Now I will call our guest faculty, Dr. Sandra, ma'am. She is the Senior Consultant Pediatric Ophthalmologist in Aravind Eye Hospital, Coimbatore. Ma'am will be talking about management of complicated cases.
Thank you, Dr. Naveen and KSOS for the kind invitation. So, I'll be showing a couple of cases of surgery in complicated pediatric cataract. So, this is a patient who has a primary posterior capsular deficit. You can see from the video that the edges of the PPC is very clearly seen, the primary PCR. So, this can be picked up in slit lamp examination just before the surgery. What I would like to say is, if you see the posterior capsular deficit, then don't make a very big rhexis, because most often you may not be able to place the lens within the bag. It may be the support may not be good enough. That depends upon the size of the primary PCR. So the size of the rhexis will be around 5 to 6 millimeters. You can do like a very gentle hydro or no need to do hydro. You can see the IOP there. IOP is around 20 only. So it's very slow motion aspiration. And because the vitreous is quite well formed in children, it will not drop. If we do a slow motion phaco with low vacuum settings. So I am using a 3-piece IOL here, which is injected into the sulcus. You can see the leading haptic going into the sulcus. So dialing the entire thing into the sulcus, and then this is the optic capture. So in such cases, you can do an optic capture within the bag, or even optic capture into the PPC also you can do. So that way you are not going to get the complications of crowding in the anterior chamber, and so the stability of the IOL will be very good. You can see how big the primary posterior capsule. There is no way of keeping the IOL inside the bag. It will dislocate or drop. So this is what you will do. And sometimes if you have access to UBM, you can even pick out these cases preoperatively. UBM, you can easily see the deficit in even in adults and children. Both ways you will be, especially if it is a mature cataract. If you have a doubt, you can see. This is a patient who has a blunt trauma. You can see the zonular dialysis here and the central cataract. So there is a dialysis extending from almost 3 clock hours. So for this limited dialysis, there is we can do CTR placement with in the bag IOL placement. So it will be quite stable. So here again, while doing the rhexis, it is very important to judge the size and stability, because we will not be able to again do a double rhexis and extend. After putting CTR, it is not possible to do a double rhexis. So initially you need to get the size right. And while putting the CTR, it is very important to see that the CTR is going exactly into the bag and not going into the sulcus or somewhere else. After putting the CTR, you can see that the bag has, so that is the correct time of putting CTR, not after you aspirate or so, because that way the stability of surgery is not there. But the only disadvantage is when you put the CTR, the cortex aspiration is going to be difficult. So here I am going with the Simcoe cannula, because otherwise you can use the bimanual. Here again using a 3-piece lens. See, most often I am using 3-piece lenses now, but it depends upon surgeon's preference. In clear cases, if you want, you can use single piece also. So here you can see that the lens is being dialed into the bag. Instead of dialing, I usually flex the haptic and put it inside, because that way your trauma while dialing is less, you are not touching the iris. And there is no need to do a PPC here, because the age, especially after putting CTR, you cannot do PPC. It is going to split the bag. So just make sure of good cortex cleanup and then close the case. This is another case of blunt trauma, where what is the difference? There you saw the cataract. Here the anterior capsule, you can see the rupture here. This whole area, the capsule has got ruptured. So then what to do? Then there is a synechiae which has formed here. So you can just go in and aspirate. Again here the IOP should have been ideally lesser than this, because you don't know the status of the PC. No need to do hydro in such cases. Just aspirate. The cortex will be very fluffy and it will come out very easily. Following that, here you can see some margins very well. So it is possible to place the lens in the bag. As far as possible in pediatric cases, the most important thing is in the bag placement. Because once that is not there, in the post-operatively, we can see a lot of pigment depositions and iritis and glaucoma. All these complications come only in cases of PCO. Everything is high when you do a sulcus placement. So as far as possible, it is better not to let the optics or the haptic touch the iris. So here you can see that the lens, whatever bag is there, the lens is there within it. This horizontally, like this area and that area, it has got extended. So you place the haptics in these areas where it can be within the bag. So if you are going to keep the haptic in this orientation, after some time that's going to pop out. So wherever you have the capsule, it's better to keep the haptics there. And in this case, I am doing a PPC also. There is one opacity here which is in the vitreous, so that is not coming out even with the anterior vitrectomy. Anyway, that we cannot go down and take that. So that is some opacity which has come during the blunt trauma. So you see the size of the PPC. In our center, usually we do the PPC after placing the IOL, but that again it is surgeon preference. Advantages of doing this is, it is the IOL is there where you are already positioned it well, whereas if you do the anterior axis and the posterior axis, then you have to definitely go and open up the bag and then you have to place it. Sometimes it may not happen, but again it depends on how you have been trained and how you are doing also. So that's a surgeon's preference there. So this is a case where there is a complicated cataract with uveitis, and you can see the synechiae here. So there is like total all the 360 degrees there is synechiae, only this area there is synechiae is not there. So in such cases, it is important to do a PI also because there is a possibility of post-op inflammation. And here we are releasing the synechiae. Thing is, you have to really release it fully. Like sometimes you don't, the synechiae may not only be at the pupil border, it may be all around. And since it is an intumescent cataract, not doing a very big rhexis here because it has a possibility to extend. So do the rhexis in whatever, even though it is small, you will see that here again now cutting and doing the double rhexis. So this possibility is there, provided you are not placing a CTR or any device inside the bag. It is possible to extend the size of the rhexis after aspirating the cataract. That is the only way you will be able to do in a intumescent mature cataracts. Here again, in uveitic cases, the very important to place it in the bag. Otherwise, it's going to be a lot of inflammation you are going to see. So here you can see the color of the glow itself, that there is a lot of inflammation inside. So this particular patient, it is just that sometimes it is all white. You will not be able to make out the status of the anterior capsule. So in this case, you can see now when I am going it, the rhexis is not coming because the anterior capsule is calcified. So in this case, you can come across this scenario. Then what can be done is you can use a microrhexis forceps and just cut the capsule. Because if it is calcified, you are not going to be able to do it any other way. So this is like in two areas you can cut it so that it won't extend, and then you can join it also. So that is that push-pull kind of technique which was like which are there in some publications. So if you don't go right in the center, you can open in two areas and then you can join it in between. So after aspirating, you will see that you have got a rhexis here also. So you can see now. So this is how the capsule was. Only after aspirating the cortex, there is no way you can get a rhexis with a cystitome in such cases. Again here, you can now go back and you can increase the size of this. So I think after putting, this is a single piece IOL being injected. After that you can extend, or you can extend and then place also. So using the microrhexis forceps again to enlarge the size of the rhexis. So as long as you are working within the area of the fibrosis, it is very safe. It is not going to extend. So you can use the area of fibrosis to your advantage. Beyond that, if you go, there is always a chance of extension. That is why I am doing this after placing the IOL. It is never going to extend because of the fibrosis. So that is the thing here. In all cases, we do PPC up to the age of 10 years because sometimes, most often PCO happens, And the quality of shots with the YAG laser may not be good. You may get lens pitting if the child is not cooperative, especially if the child is delayed or some other reasons are there. So doing the PPC with or without anterior vitrectomy will solve that problem. Above the age of 10 years, even if PCO comes, you can get a good cooperation with the YAG. So this is a patient who had a membrane. So I'm just telling some cases after aspirating the cataract, you can see it looks like a PPC here. So, and it's also some kind of anterior segment dysgenesis where you can see the iris is not well developed. So here again, after doing the rexis, you always use a, like you pull to the center. You have to use a centripetal rather than a tangential force. And here we always, mostly we go with the coaxial, only if it is not coming we tend towards using bimanual. And see here the membrane, and the membrane can be actually picked out and removed with your forceps. So sometimes the membrane is just there. You think that it is attached to the posterior capsule, but it is not. So after that, I am just cutting and extending the rexis here and doing a double rexis and completing the case, and then placing the IOL inside. So there now you see the almost it is so clear. It didn't look like there is a membrane at all. So you can always try that. Just try to remove the membrane. It may come off. If it is not coming, then you can use a cutter to do the membranectomy. So this is what Madam was talking about, the PHPV cases, which are usually very complicated because it can be a combination of anterior or posterior PHPVs. So in this case, almost it has like it was really shrunken bag and with posterior synechiae. So trying to release the synechiae here, it is not, and you cannot use a lot of force because one thing, it can cause bleeding. Secondly, the iris can just come off. It can create an iridodialysis. So you have to be very careful. And you see that the bag, the cataract is so small. It is just coming out. It is like fully, you can see the vascularization in the middle. And it is like partially absorbed kind of cataract. So this is like leaving the patient aphakic in this case. Right now just rehabilitating with the aphakic glasses or so. You can use a cutter also to remove it. So that here after removing the membrane, I am trying to just dilate the pupil and see what is happening under the membrane. Yeah, just for help to see whether the cortex is there. There is some cortex which is still remaining. So you have to make sure thorough cortical cleanup is very important. Doing a limited anterior vitrectomy in the middle, and this case's PI is very essential. So the important thing is in any complicated case of pediatric cataract is a clear visual access. So he can see the PI which was done here with the vitrectomy cutter only. So you can use the same cutter to do the PI, or you can use a PI forceps also. Very important that the visual axis should be clear. That is the aim of the surgery in any pediatric case, whether you leave it aphakic or with the IOL. This is another case of PHPV. It's a younger patients, all patients till the age of 2 years I do a scleral tunnel. Beyond that we'll decide like whether we can do clear corneal also. But very young patients, scleral tunnel is better because the AC forms much well. Now you can see the extent of the membrane here, and you can also see the vascularization. So after putting in the 3-piece IOL in this case, I am going down under the IOL, and it is not possible to open that with the, so I just made a nick with the side port forceps and then trying to remove the membrane there. You can see that vessel, the vessel is cut now. In case it is bleeding too much, you can use a cautery. The retina people have the endocautery which can be used to cauterize the, it will be a better idea to cauterize it before you cut it also. In case it's a very big vessel, we will cauterize it and then cut it. Here you can see the bleeding has stopped now. This part I left because already again it was very much vascularized. Again if you remove that, it will create a lot of bleeding, and the visual axis is clear. And that area if you remove, maybe the IOL also will not be stable. This is a patient with aniridia. So here you can see the small iris stumps only remaining. So aniridia with a total cataract. Aniridia with partial cataract, very early PSCC and all, I just leave it as it is. Only if the aniridia is having total cataract, we go and do surgery, because we are not using any devices for aniridia, iris and all we have not used, because of the high risk of glaucoma in such cases, and limbal stem cell deficiency. So many problems are already there. So we don't want to create harm in such patient. So here doing the rexis and slowly aspirating the cortex, you can see that it is there, a PPC is also there in this patient. So in any case of mature cataract, you need to be very careful. You don't know the status of the posterior capsule and PC. So here now I am putting in this area, it is a good idea to place a CTR in cases with aniridia. One thing is, it will give more stability to the bag. Another thing is, the incidence of PCO will reduce later on. So it is always better to put in a CTR. And then followed by 3-piece lens injection inside the bag. Following that, we have to do that central membrane removal again. So I like this way of putting the lens. I'm very used to doing it this way instead of dialing things inside. The dialing thing is more difficult for me. So earlier I used to use a lot of single piece, but the problem is, since we are doing PPC after putting the IOL, if there is any problem, if the PPC extends, or if there is, it can just split, you can never predict, then we have to explant the IOL. There is no way the IOL will be stable. That's why again reverted back to 3-piece. And here again you can see that membrane is being removed now. Actually there is no PC dehiscence. It just came off and I left it. So since the CTR is there, I did not do a PPC in this case. The PC is clear, so we can just leave it. Coming to a case of lens coloboma, this is a patient with Marfan syndrome. You can see the height and the span, the fingers, and he had all the features of Marfan and also cardiac thing also. Marfan's with a lens coloboma rather than a subluxated lens. So in this case, you can see here all the zonules are intact, but the shape of the bag is very irregular. So in such cases, it is difficult to place the CTR initially, because it can just puncture and go out. CTR will go in easily if the bag is shaped in a sphere. In a subluxated case, you can do it, but in coloboma cases, that's why I am aspirating without putting CTR in the beginning. And then, so how to do it now? You can use iris hooks. You can use iris hooks to stabilize the bag, pull it apart, and then that way the shape of the bag is little better now. Now I will place the CTR. So if you go initially, it can just cut through, create a hole and go through the bag, and it will go into the sulcus. So this way of placing a CTR is safer if you see that irregular bag shape. This iris hooks will provide additional support to your surgery. Now CTR is in place, iris hooks are also there. Iris hooks can be there until you place the IOL, so that it helps for dilation also. This IOL again is placed in sulcus with optic capture. So you can do that. So in the end, there is a good centration compared to before. Even in the mid-dilated state, you can see that it is very well centered. This is post-operative day 1. So there is no problem in this case. And usually what happens in such patients with coloboma and all, the cylinder is very high. So even though it is a clear lens, they cannot rehabilitate because the cylinder is very high. So that is why it is better to do the surgery, even though the lens is almost clear. Then coming to subluxation with the Ciani placement, I find it's much easier to do Ciani with a scleral tunnel, because putting every instrument inside is easier with the scleral tunnel rather than clear corneal tunnel. Here you can see almost half and half subluxation. Ideally, it was easier to do in an earlier case, but I don't do till the age of 10. This Ciani. It's very, very difficult in younger patients. Incidence of PCO is very high, and it really beats the purpose. So at that age, I do lensectomy. But in older patients around the age of 10, can do Ciani also. Here you can see that the bag is being stabilized with the iris hooks and aspirating the cortex. And after this, so you have to do the Ciani, the tunnel for the Ciani in the area of maximum zonular weakness. So in that area, you do another tunnel here. You can see that So because that's where the ring is going to come, and you are using the Prolin suture which is tied to the eyelet. Single eyelet only I use, double eyelet becomes very difficult to manipulate. And now I am using this needle, bent 21 gauge needle, which is coming out through the scleral tunnel, and then threading the both. You use the double armed Prolin as double armed only. So then both the things are taken out of this incision, and then on tying. You can see now this is the second. So this is why I said scleral. Scleral corneal means it is very difficult. Sometimes it will just come in through the, it will include the tunnel also. So scleral is easier. So here you can see that this eyelet is being tied here, and you can see the bag has stretched. Okay. So now after this we need to close this incision also. You see here the bag which was here like half and half, it is fully stretched now. Now chance of PCO is very less at this age group, but in younger age group I think this kind of manipulation is difficult because the anterior segment is very shallow. So now the IOL is placed inside the bag, and that is, and the end of it I am using Simcoe, just didn't want to create any vitreous disturbance there. So there is no vitreous disturbance at any point in this case. And then you have to suture, you have to make it quite tight. With the chance of post-operative hypotony is always there in such cases, so you have to nicely form the anterior chamber. So that's extremely important. Then just another 2 minutes, I think. If we can stop at any point of time. I don't know if the next people are already there. Okay. So this is membranectomy. You can see this can happen in any pediatric case. The IOL is in the bag and there is a membrane. So you just have to explain it correctly to the patient. Don't tell one surgery, one for lifelong thing and all, because the incidence of PCO is very high in a younger age group. Thing is, in a single piece IOL, to lift it out of that bag actually is difficult because it sticks very well to the bag. That's again the 3 piece is easier because there is some spaces there. Whereas single piece you need to, sometimes it's so stuck you think the bag is going to just break and come out when you are trying to lift it to do the like so much of, you can see there is so much. This case was like operated at the age of 1 or so. Within 6 months got a very dense membrane, and now we have created again a PC opening. It only can happen once. It cannot happen more than that. So when you operate on very young children, placing IOL at the age of 1, you need to tell them this possibility is there. Otherwise, they are going to be maybe not very happy. See this case operated elsewhere. Full lens is in the sulcus. Means the lens has been initially placed in sulcus. So after some time, this is what will happen. The pupil capture will happen. PCO will happen. And this is universal if the case is going to be operated at a very young age. So if you are not able to place in the bag, just leave it aphakic. Later on we can place secondary IOL. At least this no point of, it is almost looking like cataract only. There is no point in doing a case like this. If you are not able to place within the bag, just leave the case aphakic. Take the case, same patient up after 1 year, and you can place secondary IOL. Now you see that so much of, see the amount of synechiae that has formed and so much difficulty because it becomes very, very inflamed. And most of the time when we see the other eye, it will be lamellar cataract and we'll be surprised. It is not a complicated case. Okay, so now I have created a space and put the IOL inside the bag, whatever it is there, not inside the bag, I'm sorry, in the sulcus, and then going underneath and now creating an opening there with the 20 side port blade, and even then just doing a vitreorexis, I think, or cutting it with the one of the 2 things. I think we are running short of time. I have a lot of complicated cases. Every case which comes is complicated. So see, yeah. So you're just cutting it with the scissor, and because if you use a cutter, the cutter cannot be used for any more cases. It will just be totally damaged. This much of PCO, don't damage your cutter trying to do it, because then the sister will be angry with me. She cannot use it for any other case. That's the end of, cutter will die and has to be buried after that. So that's all. just pupilloplasty if you want to see. This case had an IOL with opacification. This is a pseudophakic case actually, our own case, but got a pupil capture and membrane which happened. And here again, just this case just trying to show what can happen in very young babies when if the surgery is uneventful, but this is a in the bag placement. There was post-op inflammation. Probably they have not put the drops well also, and that can create, you never know, because parents think they are putting inside the eye, whereas child may have closed the eye, and then you can do a bit of pupilloplasty also so that it doesn't happen again. Then go and do the, this is a phakic case with a eccentric pupil where we have just done a like centered the pupil up a bit. I think that should be enough. Yeah, that's all. Thank you.